Panel, and I think as the morning evolves here, I think we're going to be seeing a little bit less of the clear themes that were outlined and more about the specific vantage points of the panelists. Because I think the last panel touched on both some of the promises as well as some of the difficulties, and I expect we may have some of the same kind of discussion on this panel. But we have, again, a very distinguished panel. I do want to note one thing before we get started. So I'm Bob Meyer. I'm the director of the Virginia Center for Translational Regulatory Science. I wore my anti-McClellan tie, so he had his Duke tie on. I've got my UVA tie on. But I was very pleased that Mark was able to join us last night and set the stage for today. So we have, as I said, 3 distinguished panelists, and I'd like to actually refer you to the biographies in the program for more complete details, but I will just list them by title. On our end, on the far end for me, is Dr. Bill Hazel.
Is there a reason I'm at the far end?
No, not that I know of. Bill is a orthopedic surgeon who became Secretary of Health and Human Resources for the Commonwealth of Virginia in 2010, and I expect will give us a perspective from the state/Commonwealth level. Next to him is Joe Antos, who is the Wilson H. Taylor Scholar in Healthcare and Retirement Policy at the American Enterprise Institute and Adjunct Associate Professor of Emergency Medicine at GW. And immediately next to me is Bob Hugin, who is the Chairman and CEO of Celegene Corporation. And with Bob, I'm going to depart from just the title to mention that he is also a graduate of the Darden School, which is, according to The Economist, the #2 school in the world for business at this point, and in fact is a trustee of the school as well. So I think my only introductory comments here are that we do have some perspectives here that the topic that I discussed with these gentlemen was around some of the challenges, but also opportunities in personalized medicine. And realizing that is an imprecise term, I would allow them to define that to themselves and to you. And without further ado, I will turn it over to Bob.
If Bill wants to go first, since he's on the far end, I certainly wouldn't.
No, I don't want to do that. I just was hurt.
Okay. Well, I want to say first, thank you for inviting me and including me here, because I really do believe these kinds of sessions are so important. When you think about the issues that underpin or even having the overarching themes that we're talking about and Mark spoke about last night, are so fundamental to the future of our society, not just from a healthcare perspective, but the economics of our society are not sustainable if we don't deal with some of the key issues that we're here and we're talking about. So whenever there's an opportunity to come and participate in a discussion that is going to frame those themes, I think it's extremely important. And it's been a very troubling one to me to see how Americans think about these issues and are so uninformed, ill-informed about it. I have 3 kids, 24, 22, and 20. They know more about, and they're all great kids and doing well, but they know more about Lindsay Lohan's rehabilitation and all kinds of issues that are not important, but the issues of fundamental, what's going to happen to our society if we don't deal with these issues is just so important. So anytime I have an opportunity to participate in a meaningful discussion when we're really trying to think about these issues in a way, because they are complicated, they are complex, and there isn't a simple answer, and there's really no great answers, and so finding solutions and integrated ways of bringing people from different perspectives is such an important part of us developing a social solution to these issues for all of us. That's one. And so when I came here, I was clearly of the view, and nothing has changed, unfortunately, in last night or this morning, that we really are in the best of times and also in some of the most challenging times. when we think about precision medicine or the revolution of molecular biology and information technology, there is no doubt we are on the early days of the dawn of an incredible revolution in terms of the opportunity to improve the quality of people's lives, the length of life, and deal with some of these incredible issues. And one of the reasons why I'm so optimistic about it is that we're finally bringing information technology into the healthcare space, where we've had a great revolution in molecular biology. Information technology has fundamentally changed most industries in our society, and those that aren't are being attacked now, and healthcare is finally one of those. As we bring those two to bear, we really have the potential for great things. We already have had significant improvements. We have, I don't know, 100 and whatever, 40 drugs that the FDA has approved already with biomarker data in the labels, almost 4,000 drugs in development today. About 70% of those that are in cancer, about 1,000 of those in cancer, are targeted medicines or very specific to a precision molecular target, et cetera. 40% of all drugs in development today are designed for a specific target, which is advancing the knowledge of science. So the talking about the next 10, 20 years being the era of molecular biology, again, combined with information technology, is a great time for us and great promise. And it is so critical because, to me, the overarching theme that really frames the discussion of everything we talk about in healthcare is the race that we have in the cost of caring for aging population demographically versus the ability to increase the pace of innovation to deal with those challenges that we have. And they are so fundamental that in 2050 we expect, or it's forecasted, that the direct care of Alzheimer's patients in America will cost $1 trillion. Not the loss of economic productivity, the direct care of Alzheimer's patients. Close to 2/3 of that same expense will be for metabolic disease, obesity, diabetes, et cetera. We've really only just begun to see the tip of the iceberg of the cost, this coming tsunami of cost, because these two diseases, obviously Alzheimer's, but obesity also, is really a disease of the elderly. And so when you think about knee replacements, you think about cardiovascular disease, all of the organ failure issues that come with diabetes tends to come later in life, and we're only beginning. We have not yet seen the real economic, and cancer is the same way. Cancer is generally the disease of the elderly, and the costs there are going to be significantly higher over the next 20 to 30 years. And if we don't have meaningful, innovative, disruptive technological change in the way we treat or disrupt these diseases and prevent them, we have major social issues. We're not going to worry about having any question about how we're going to spend discretionary funds in the U.S. There will be no discretionary funds, or we'll have to change the way we treat seniors fundamentally. So it's a very bright time, but it's a very challenging time. And I do think information technology gives us the opportunity to change some of these trends. I do think it's something that we've got to be very focused on how we do it, and all the terms that we all talk about, interoperability and those kinds of issues that will allow us to take advantage of data, is going to be extremely important to us. And I think that we have the other issue I think that we have to, in this discussion, have to recognize is that it's going to take time. The tremendous speed of which we can sequence the genome, we were talking about this privately a little bit earlier, is phenomenal, and the cost of an exome sequencing now is down to about $130, $140. The full genome is less than $1,000 to sequence, but we have not yet even established reference genomes, so we have the ability to really analyze the data and say, how can we use this? For full disclosure, we're the leading investor in Craig Venter's new company, and I serve on the board of Human Longevity, Inc., to help us build multiple reference genomes, so we'll actually be able to use the data from people's genomes to say, this is really the analytical tools and machine learning, artificial intelligence, to really understand what are the causes and where interventions can be done. And the other area that I was intrigued in the discussion earlier was in prevention, and it's also a soapbox that I have been on for a few years. And one of the issues that strikes me, we talk about insurance, and again, I'll be on the soapbox. I think the idea of pushing people into exchanges and out of employer-sponsored health care is very, very bad for our society. That people spend so much time at their employer, there are few places that have the opportunity to, in a constructive and positive way, to influence behavior. And I think that when we give up that lever, and prevention is extremely difficult to prove its benefit unless you have a population and you can actually demonstrate the experiments. And I'm going to give you an example at our company, and we're self-insured. I think it's very important. We saw 6, 7 years ago a number of premature babies born in our population of either employees or families of employees. We haven't had one in the last 6 years, as we instituted a very aggressive education program about neonatal care, et cetera. We saw tremendous costs from weekend warriors who 50-year-old guys thought they'd go play basketball again or something, and we instituted programs of education. Our health costs this year are the same as they were last year per person. Next year, they'll be slightly lower than they are projected next year than they are, including pharmaceutical usage. And so I think that prevention has to be an important part of this solution. We have to innovate, we have to prevent, we have to increase wellness, because the economic consequences of not doing it are very significant. And I do think the knowledge that we have does make this more precision medicine, personalized medicine, but I think we should make sure the discussion is under the arch of the issues that are fundamental and are driving them, and we have to recognize that we are going to need to be patient. We're going to need to find specific examples of demonstration tests and cases that we can do to illustrate, because we're not going to have a fundamental revolution in 19% of our economy and say, we did it this way yesterday, we're going to do it that way tomorrow. We have to recognize that we have to be leaders and find the circumstances, whether it's in knee replacement or hip replacements, where we can illustrate that we can identify in transparency the costs and outcomes and measure them and demonstrate what value is, and then produce the kind of, and the same thing with all of the personalized medicine. We've got to identify where we can create value, demonstrate that, and then extend it, because we don't have the financial resources to have a revolution to be able to change things in a fundamental way, because we are incredibly constrained of our ability to spend more, and anything we spend comes out of research or costs that have to be taken out of someplace else. So it is an incredibly exciting time from the seat that I'm in terms of the revolution, the opportunity to really discover, develop, and bring to market revolutionary, disruptive new technologies that are going to change people's lives. I do think the knowledge we've made in cancer in terms of really understanding the process of disease and the fact of the incredible heterogeneity of tumor mutation has led us to concern about the speed we're going to come to be able to have targeted medicines, but it's incredibly exciting. And what is also very significant, I think the lessons that we're learning here at great medical schools and hospitals like here at the University of Virginia, that experience in all the areas is being able to be transferred to other areas of research. And I think we're going to have to make sure we invest more in the areas where we're going to have the kind of innovation breakthroughs like in neuroscience, in metabolic disease, and in cancer. So great to be here, and I look forward to a robust discussion.
All right, thank you very much. And Joe, you're up next.
Bob Meyer, our moderator, introduced us. He mentioned challenges and opportunities. Challenges, well, he did say that. That was a mistake on his part. But he did say challenges and opportunities. And I'm thinking, that sounds like money. And money does represent challenges and opportunities for precision medicine. substantially higher cost, but at a more moderate cost, or more moderate increase in cost. If we can't do that, then we won't have the resources to spend on other essential resources, other essential needs. Yes, it's true that for an individual, my health is the most important thing to me, and especially if somebody else pays for it, the sky's the limit. But we're talking about societal decisions. We're talking about group decisions. We're talking about expectations have been raised to a level that are pretty astounding when you think historically, or even if you think over the last 10 years. Our expectations about what we should get out of the health system are truly amazing. And I know Bill is living up to that for his Medicaid beneficiaries every day, but I live in Maryland, we don't do that. So we try, but we don't. We don't succeed. We don't succeed for Medicaid. We don't succeed for any Medicaid. Our expectations, rightly so, they should exceed our grasp. But our grasp has to be able to grasp something that's realistic. So we have a fundamental difficulty with health financing. Precision medicine didn't invent it. Precision medicine might ultimately be a cure, but we have to know a lot more about how it works and how we're going to pay for it. So, just to
Oh,
It's been very good what he's been saying, though.
He's brilliant. He's brilliant.
well, you know, we actually, it's kind of embarrassing. We have these microphones at my office, and I usually know how to put them on. Well, okay.
You just were so excited to talk.
All right, well, I have a big mouth anyway, so, you know, you'll in a minute, you'll ask me to shut it off. Okay, so, you know, what people have been alluding to, or speaking directly about the importance of the individual. By the way, it's not the individual patient, it's the individual person, the individual consumer. If you become a patient, it's already too late. Well, maybe not, but in any event, you know, where things really begin in health is with ourselves. Yes, it does reside to some extent with our genes, but it also resides to a great extent with the way we were brought up, the kind of incomes that our parents had to finance not only what appear to be directly health needs, but also our education and our understanding about our place in society. So these are all very interconnected and complicated things. The health sector tends to ignore all of that, of course. It's too messy, right? And what we really care about in the health sector is how are we going to get paid and what's the next new scientific gizmo.
First he picks on orthopedists, and then he picks on the whole health sector.
It's easier that way. It's not personal. It's not personal. It's very general. You know, I go to the doctor too. Of course, I'm more afraid than you are, but yeah, well, maybe not. You know more about it than I do. In any event, you know, so we need to take a broader view of all of healthcare. We need to recognize more, not just as a system, not just as a society, but as individuals, what our individual roles are in maintaining our health and avoiding the doctor's office, because that's the first line in reducing health spending. Don't spend it. And what I don't mean is, don't spend it if you need it, but don't spend it if you don't need it, and try to avoid needing it. That's obviously the key. It'll also require a broader definition of how medicine should be practiced, and a redefinition of the roles of physicians and other health professionals. I'm sure that's going to be, you know, welcomed by every physician in the room, but it's coming. You know, nurse practitioners, even in New York State, nurse practitioners can now legally do things that they've probably been doing for decades. And thanks to technology, a lot of things that were impossible to do by anyone other than a physician with a vast amount of training and experience can now actually be done not only safely, but perhaps more effectively by someone who does those kinds of, we now call them routine procedures. They used to be very complicated, but those routine procedures on a regular basis. So we're changing the role of everyone in the health sector, including the consumer. But it also requires a new approach to payment methods. And, you know, one of the things that Mark said yesterday, I don't know if everybody caught it, but it resonated with me. You know, the replacement for the sustainable growth rate in Medicare, that's a bill that says we're going to go to alternative payment models. Didn't say what they were, but, you know, by golly, we're going to go to alternative payment models. And the implication is that we'll know them when we see them? No, we won't. You know why we won't? Because alternative payment models are fee-for-service. Now, why do I say that? Well, it's because all the alternative payment models that I'm familiar with, and I'd be delighted for somebody to come up with an example that would disabuse me of this, but certainly all the common ones are based on some sort of unit of measurement, some sort of payment. You add them up. You know, bundling is actually one of the major themes. I think it may be the most important theme in a sense because it is a philosophy. It's not just a payment, you know, a specific payment method, and I'll get to that in a second. But the reality is that you build up payments with building blocks. It's like Legos, and if you step on one the wrong way, it hurts your foot. The idea that we're going to get away from fee-for-service payment is both correct and incorrect. What we want to do is we want to build up payment systems that start from the atoms. We want to develop molecules. We eventually want to develop whole payment systems. But in the end, they do go down to these very basics. And we want payment systems that are flexible enough so that when science changes, views about practice change, attitudes change, and our views and our realities about our resource availability change, that the payment systems also adjust to those realities. Our current payment systems don't do that at all. And I think this is a big challenge for precision medicine. The other fact is that payment, of course, is the lubricant in the market economy to any change whatsoever. You know, there's a surgical phrase that I wish had come to mind before right now, and maybe you can fill me in on what it really is, but it's something like if you can't cut it, you can't cure it. Well, if you can't pay for it, it isn't going to happen. And if you do pay for it, it may not happen the way you think it's supposed to happen, but by golly, something's going to happen because payment is there. So payment is really a critical component of this because it can drive the kinds of reforms that people who talk about precision medicine are really dreaming of. But without payment, a lot of those things aren't going to happen. And it's no coincidence, in fact, that when Mark was talking yesterday, everything that he talked about that was a Medicare project was a Medicare payment project. And the reason is that that's the only tool Medicare has, but it's also the only tool there is. Anyway, I consider that upbeat. I'm an economist. I don't know about the rest of you people, but I think that's probably a good thing. What it says is that the health sector responds to financial incentives. Now, of course, creating a new payment system doesn't guarantee the result you want. It gives you some result, not necessarily the one you expected. So I think accountable care organizations illustrate that regrettably too well. So they set up payment benchmarks for accountable care organizations based on the past performance of the providers who decided to group together in some manner or another. I'm sure that the people who decided on that thought that was fair. After all, you don't want to hold somebody to a standard they can't meet. However, that does hold somebody to a standard they can't meet. What it does is it favors the poor performers because their bar is low. And that incremental move up is not some major insight into medical management. It's what everybody else does. So that's easy. What about the good performers? Well, they're in trouble because they're already up there. Their next move is difficult. And so unfortunately, the accountable care organization structure is really designed to fail, and it has. a number of very good system performers have dropped out of the Pioneer ACO program, even though they may have done pretty well in kind of the first round that they were in, but they realize that there's no upside for them. Wow, why? Because the benchmark jacks itself up. Now, so is there a solution to that? I'm not saying there is. I'm just saying this is one of the many classic difficulties of trying to put what seem like, on the surface, sensible financial incentives in front of the health sector. There's always an exception. There's always a problem. Never works out the way you think you want it to do. Now, this also says something about who's doing that. It says that if you have the government saying how they want things to be done, the government has not only the power of the person, it has the power of the badge as well. And so when Medicare says we want to do something, guess what? Everybody says, yes, sir. And even if it's a demonstration, so many entities signed up for many demonstrations over many years. I ran the office that did those. It was a different name. It's now called the Innovation Center, but decades ago I ran that office. And so you got, that was a somewhat less threatening time, but in a more threatening time, threatening because healthcare costs have risen so much, because the financial pressure is there, and because there's actually a lot of public attention to these projects that didn't exist 25, 30 years ago. But so it's a threatening time. And so when you announce the ACO demonstration, what happens? Well, people say, oh, I want to sign up. And the ones who aren't too sure say, well, I'm going to sign up because I'm going to learn how it works. And why is that? Well, that's because they want to get ready. They want to get ready for whatever it is that happens, and they think maybe they will get some insight into that. Well, maybe they will, and maybe they won't. But in any event, the problem with the ACO program, among others, is that it didn't give the ACOs, in my opinion, enough freedom from regulation. It basically dictated what they were supposed to do, and so they tried to do it, and many of them failed. Very few of them succeeded, and the ones who were successful probably aren't going to come back, or many of them are not going to come back. So, but did the ACO payment system move away from fee-for-service? And the answer is no. It is wedded to Medicare's fee-for-service payment system. The way it works is that if you are successful, you get a bonus, actually not at the end of the year, but sometime later. Now, there are two problems with that. The first one is, of course, there's no price competition whatsoever. There can't be. It's the Medicare payment system. And the second one is that unlike true private sector initiatives, where you can more quickly determine how you're doing and you have a chance to react to it, maybe send out a press release saying how great you are, but more likely say, oh, we messed up here, let's change it. Well, the ACO program doesn't work that way. So that's the nature of a lot of these projects that Medicare is putting out. They can't help it. That's the nature of the program. But it does raise concerns, in my opinion, about that broader sense of precision medicine, the broader sense that Mark was talking about last night, that goes beyond the focus on medicines, prescription drugs, to the way we deliver health care. And it does suggest to me that we should look to good private health plans for our guidance, and hope that the Medicare program can follow along. In any event, what's the problem with health financing that I haven't mentioned? Well, one of the problems.
You mean there are more?
Yeah, there's a big one that I have in mind. Well, I tend to be optimistic this way.
Sounding that way.
Yeah, I'm not picking it up.
Economics is supposed to be the dismal science, and I try to live up to that every day. Yes.
But of course, you're supposed to have several opinions, not just one. Yeah.
Well, I disagree with myself on a regular basis. I'm very disagreeable that way.
I can see that.
So, among the many big problems with our insurance system is its narrow short-term focus. And I think this is really a huge problem, not just for precision medicine, obviously for precision medicine, but it's a problem in general. So, what do I mean by this? Well, the business year is 1 year long. And even though most people who have employer-sponsored coverage tend to stay with that plan unless the plan changes in some way, leaves the company or whatever, Certainly, most Medicare beneficiaries are in the traditional Medicare program, so they don't leave that program. Medicaid is a little iffier in that regard, but I think they're frequent flyers in the Medicaid program, so you kind of know who's going to come back. The reality is that insurance companies have a core of stable customers, but they run their businesses to reach the bottom line each year. And they are not organized, the financing system is not organized to look broader than that, to think of expensive health treatments as potentially an investment and something that you might invest in because it might pay off down the road. Now, we all say this, but when you look at the practice of insurance, and I include Medicare in this big time, that's not how it works. We all know that's true, or at least we hope it's true. Am I about done? Okay, I'm about done. So that, I think, is maybe the biggest problem we all have to work on. We have to work on the nature of financing. It's not a simple problem. It is going to get in the way of the adoption of what everybody here calls precision medicine, whatever you might mean by that.
All right, thanks. And I apologize for
okay.
stepping in, but
I already said too much.
well, we need time for discussion too, and I'm sure you'll have plenty to say.
Oh, he's
in
not
that.
prompted any discussion.
So, so please.
Thank you. As a recovering orthopedic surgeon, precision medicine to me meant measure twice and cut once. You know, it is, and so very, really simple-minded. And unfortunately, being a secretary now, I'm not a subject matter expert on precision medicine, but there are a lot of other problems here. And I have to have a formal caveat as I begin. The opinions expressed in this 15-minute segment are not necessarily those of the management. Okay, they haven't been vetted with anybody. I'm just free associating right now, and being undisciplined, I tend to respond to things other people say, like, Bob, employer-based is part of the problem, but that's okay. I think the challenge we have thinking about precision medicine is that we are building on a failing platform. Long and short of it is we're building on a failing platform. You know how many Virginians it takes to change a light bulb? At least a dozen. One actually changes the bulb, but the others sit around and reminisce about how good the old one was. And what I'd like to do is reminisce for a minute a little differently than Joe did. But Rick Shannon has said, healthcare is already reformed. We just weren't paying any attention. We're now spending 85% of our money treating chronic diseases because we were very successful treating acute stuff. That came up earlier in a conversation. What we're looking at now is chronic disease. The system was designed for acute change. We are not organized around that. Financing is an issue. I happen to agree with Joe. When insurance looks to next year and the corporate says, boy, that plan's cost too much, let's get another one. What is the incentive to get me to 65 when we're going to dump you all on the taxpayers anyway? And that's really the fundamental issue there. We don't have the long term. And when you look at your health payments, we start thinking about prevention, when that lines up with where you're going to be when you're spending money at 80, then I think we've got something to think about. Maybe we should be hiring our insurance companies like we hire our financial planners and our banks, people that we expect to have a relationship with for some time who share our values. And I think that is a fundamental flaw in the system. Our organization is screwed up. Part of the issue I think we have is Medicaid. Mark said last night that we all wanted to get rid of the SGR. That's because nobody's going to like what's coming, to be honest, because it's going to involve some significant systemic change in how we practice and who does what. It has to, because what we're doing is not working. And some of you will look at me and say, well, how's that? Our workforce is an issue. And as I listen to the changes here, yesterday I got a letter from a delegate who got a constituent letter. The constituent was complaining because her 8-year-old son was a Boy Scout and had been camping, and he had this big bruise on his leg, and now he's going to the pediatrician because he's got fevers and chills, and she is convinced he has Lyme disease. The doctor ordered the usual panels of things, and she is absolutely convinced that this boy needed antibiotics, but yet the system is so antibiotic adverse that this child is not getting what he needs. Now, I don't know what the kid has, but Lyme is a reasonable thing, and she's lost in this, and they're writing to us, what do we do in this situation? The problem is that when you graduate from medical school at 28 or 29 and you finish your residency at 32, is it reasonable to expect that for the next 35 years you're going to practice an updated standard of medicine? And when we look at the rapidity of change with what's happening here and the things we've talked about, how do you do that? And we don't have a training system to do that. The supercomputer model came up earlier, and we need, I think, to turn our healthcare workforce from the supercomputer, which are people like me, where society invested a lot of money up front to create a supercomputer. I need to be a network handheld right now. It's far more adaptable. It's valuable. These things change every couple of years, and we can keep them up to date. We look at opioid prescribing, and I'll tell you some examples of where orthopedics has failed. This is another thing. We need some modesty here about what government can do, what the profession can do, and what industry can do. And we are driven by the need to get to the next election, the 2-year budget cycle, and to keep our stock prices up. And the modesty that has to be here is that these things that look to be improvements often aren't. In my time in practice, leaving Mayo at 1988, well, the thing that's been resonating with me most recently is the drug reps came into my office and said, this whole model of addiction treatment is wrong, or opiate treatment is wrong. You can prescribe these opiates safely for post-op patients. Pain became the 5th vital sign. And what do we have today? We have an opiate epidemic where the problem is iatrogenic. We didn't predict that. We weren't modest enough to look skeptically at the changes. And now, since 1998, I think we've had a 4-fold in opiate prescriptions, 4-fold in deaths. We have more opiate deaths in Virginia than we do from automobile accidents. That's not precision medicine, but it's the danger of an industry-driven system that is pushing us to places where we don't actually know what the outcomes are. I switched a polyethylene component in my knee replacements because I went to the newer, better one, and in 2 years they all failed. It was new, it was better, the marketing was there, and it failed. Somebody forgot about the treatment process, breaking up the cross-linking, and they broke down. Metal on metal hips I was doing when I left practice. That was the new, latest, and the greatest. It's going to let young people. I saw an orthopedic surgeon who ran a marathon in Asheville. I said, what the hell is the matter with you? He said, I got metal on metal, I'm fine. And now we're finding the metal in the bloodstream. And so these are improvements that aren't. It takes a long view, which we are not able to think about. So these are problems. And above all, when we look at this need to have value, Joe, correctly, Bob says 18% of GDP. And a few years back, I don't know what it is today, the second most expensive country in the world, percent of GDP spent on health care was Switzerland, spending 11.5%. Now, Joe, how much is 6.5% of GDP? I ask you because you're a nerd. You should know this. I'm sorry, you're a policy expert.
My phone will tell you.
Yeah. Now, well, let me give you a clue. 6.5% of GDP, there's a line item in the federal budget, you can Google it, that's 3.5% of GDP. That's the entire defense spend. We're spending twice the U.S. defense spend in excess of Switzerland on health care. We are, roughly. I mean, you can quibble 6.5 and 7, but it's a rounding error. The money doesn't mean anything. The numbers are so astronomically big. And when you go to the Virginia Association of Counties, where they're worried about their economies, have any of you all lost a job to Switzerland recently? No, we're not losing jobs to Switzerland in this country. Governor McDonald, who appointed me, Bob's for Jobs was his bumper sticker, creating opportunities for all Virginia. Governor McAuliffe kept me. 21st century economy for all Virginians, right? Those are the things. In medicine, in what we are doing collectively, is killing the golden goose. Now, having said that, when you look at proportional contributions to premature deaths, healthcare, I don't know how economists do this, someone will have to explain it to me, but everything you say says that the healthcare spend accounts for about 10% of avoidable deaths or years lost of life. 10%. Where 18% of GDP gets 10%, 15% social, 30% genetic, 40% behavioral. So I ask, as we consider this topic of precision medicine, where should the state put the dollars? I mean, one of the things that we have to think about in all this is much of this research is subsidized. The NIH, $215 million for this grant for the million lives that has already been told is not enough to make a difference. You know, because of the subpopulations, we have to think about where we put our money. And being Secretary of Health and Human Resources, what I recognize is that you know, we've seen a relationship over time between educated individuals and healthier individuals. But we are struggling. We have to add $310 million this year to K-12 funding for rebaselining at a minimum. We have a $48.5 billion. My budget is over $13 billion. $9 billion of that is Medicaid. $1.5 billion is mental health, and they're not totally separate. So where do I put the money? Do I feed kids so they can learn in school? Do we deal with housing stability, which shows that improves educational achievement? Do we do transportation so that people can get to work and we can attract industry? Or do we deal with public safety? Those are the things that we're competing with in the drive to fund all of this new project. And it's really important because those same things follow down to individuals. When you ask people what they want food, they want a house to live in, they need a car to get to work and get around, they want their kids to be educated, and they want a safe place to live. Those come before health care. I don't know why our people don't get that we're much more important than those other things. But that is the order of things that people want, and that's what politicians, I work for politicians, I know. That's really the priority. So we have to remember that. The next thing we think about is the value of what we do writ large. As we talk about value healthcare, value means something meaningful to an individual, or to the business owner, or to the governor, or to UVA, over the total cost of that episode of care, which we have to be able to measure to get to. So the real question here as we go through this is, who gets to make those decisions? Who is the buyer in the healthcare marketplace? Who is the seller? Adam Smith, there are 4 criteria for the invisible hand to work: a willing buyer, a willing seller, complete transparency, forget about it in healthcare, and no barriers to entry, which we create every day. They're regulatory barriers, they're capital barriers, they're payments. So we need to think of all this wisely. So anyway, talk about what state does for a minute and what our tools are. Governor has the bully pulpit. He can go out and say anything, and governors will from time to time do that, despite their best advice. But you know, we have to look in our, are we talking about an economic development tool where we want to support the industry and take advantage of the military background? If you look in Virginia right now, you've got your next-gen DNA sequencing program. VCU has a Center for Biomolecular something, I can't read my writing. GMU has a brain initiative. Virginia Tech has the Virginia Bioinformatics Institute. Everybody's getting into this business. GW is over in Virginia with the Center for Biomolecular Science and so forth. We've got the VA and DOD in ultra-strength doses, and we're happy to have them. Let me be clear about that. So we have all of these players in the market. So we want them to be successful. We want this to be a good business, and we want to do that. So who drives it? Because the stock prices and economic development and jobs does not necessarily turn into better health care, witness my metal and metal hip replacements. And so how do we balance that? So as I look at just the issues that we have, where do we put our money? But workforce is an issue because this precision medicine requires a lot of computational power, and we do have that in Virginia. We have Center for, we have the computing center in Danville. We've got Virginia Tech. We've got the supercomputer. So, and we're big in that industry, and as a replacement for lost defense, we're good there. Workforce, there's getting people who can actually crunch the data and deal with the data is another area, and how we educate them and whose responsibility that is a problem. In terms of the workforce for healthcare, we do have scope of practice. You heard that mentioned earlier. how do we bring people, workers into the system that don't fit the conventional requirements because they have expertise and they can add to the patient care team? And I think we really need to think through that. That's something that we do. We do the licensing. Earlier, Stephen mentioned the prescription monitoring program, which works, but only when people use it, and we don't necessarily require that. We have a health information exchange, and frankly, one of the problems we're running against is high-tech programs in the government sector have generally been failures for the last 10 years, and we are swimming upstream when we try to convince the legislature that they should put more money into these. Witness, the big one was, of course, the marketplace, and now it's working better, but that taste of failure stays in it, and so we're swimming upstream there. We have the whole data piece. Privacy and cybersecurity is a huge, huge issue. So how is this data secure? How do we get the agreements to share? I have problems in my own agencies getting them to share, whether it's IRS rules or federal rules, and the feds are beginning to put this together for us, but these are things the state can actually impact. The all-payer claims database could be useful, but we have resistance to that amongst the insurance players who look at that as proprietary information. We can help you with cybersecurity. The disparities issues came up. Who pays? When the private world decides they're going to do this, and then the public world decides that's not fair, and we got to get it for everybody. So how do we pay for these new medications and so forth when we have the budget that's restricted significantly? Virginia has not recovered from the recession yet. We're doing better this year, but sequestration is eating our lunch. We lost $9 billion in defense contracts in Northern Virginia between 2011 and 2014. That's our tax base. 34% of the Hampton Roads economy is military. One move in the defense budget will wipe out 3,000 civilian jobs. It takes a lot of job generation to get that. So we can build some of that back up in healthcare. But so there are things out there that we can do as a state. And the issue here is, I think, when today's election day, what do folks running for office offer the people? Solutions to their problems, technical answers. We can do this, this, and this, and I will make this happen. But the problems we're dealing with are ones where, they said earlier, who's responsible? I guess I am. I'm the secretary. But I don't have the answers. So this requires people who don't want to be in a room together, who can't stand each other, to sit down and figure out how to make this work. And we need to break the federal, people talk about silos, verticals, and we've got the brain separated from the body because we've got behavioral health, and we got physical health, and we got the health department, and we got health professions, and we got social services, all separate. We need to get those things thinking better together if we're going to make this work. That's going to require some adaptive change, and we're going to need people out there supporting it. So there's a lot here to think about, and I'll stop there, Bob, and let you go.
Thank you. Thank you. Actually, fairly sobering stuff. I think I need an SSRI, but I'm not sure which one.
Precision medicine might be able to help.
So I actually will open it up for questions. I actually would like to come back to one from the panel, though. So, Mark's got his new center from Duke and the Fuqua. We have our center here. I'd like you, by the end of the time, I would like to come back and have each of you say if such a center or a network of centers, which Mark talked about, could address an issue that would be helpful to you, the challenges you all face, what would that be? So that'll be a placeholder, but let's open it up for questions here. Rick. Can we have Mike? And I think we can leave these on as long as we don't say anything sotto voce.
So, Bob, I want to ask you a question. First of all, I agree with you. I share your optimism that never before have we had tools like this in biomedical discovery to really understand disease pathogenesis. I do think the take-home message for me from the meeting is this has to be done at scale, both to keep the fixed costs at a reasonable level and to do away with the balkanization of science that Bill actually alluded to in his litany. Every one of us have a little one of these things, all of whom are trying to deal with this huge issue that is really a function of big data. we've got the tools. You know, the question, and I think the second thing is all that very impressive list of 44,000 drugs in development. Many of those targets actually emerged from academic industry partnerships. So I'd be interested from your perspective in two things. One is, from your perspective, what constitutes the perfect academic industry partnership? Because you do a lot of them. And then secondly, this is the waste part. How do we do away with or address this issue of irreproducible data that leads to so many false starts as we try to figure this out?
Good, tough questions. Could like easier questions next time, Rick, if that's okay. No, sorry, just kidding.
You're stalling. Get on
Yes,
with
thank
it.
you very much. I'll answer your question first, Bob. No, I do think a lot of these things are related. And I think one of the great things about the American system is that we have this competitive situation where you can be the Dana-Farber Cancer Center or Memorial Sloan Kettering, MD Anderson, and compete for ideas and do a lot of the same things. I think, though, the reality of where we are today, we have to take a more holistic view of this and not change that kind of market-based solutions, but ensure that we're as efficient as we can. And so I am going to answer the question about partnerships in that vein. I think that we as a company have to start with our own internal strengths and having internal organic research. We say these are the areas where we believe we have a competitive advantage in terms of knowledge or technology or intellectual property, and say, okay, now, how do we accelerate that development through iterative learning and sort of campaigning on a technology or an area of research that we believe is fundamentally leading to a disruptive technological change? And we go out and find those parties in academic medicine that share, let's say, protein homeostasis, for example, an area where we believe we can have a major impact. And so we want to find those institutions that share our vision about where we can take. And then, as opposed to keeping it to ourselves, we believe in sharing it and saying, we have to find win-wins with as many people who share our vision with it. And that way we can take a longer-term perspective, because we won't have answers for 10 or 12 years in many of these cases. So we have to believe that we're investing with people who share our vision and share our view of the long-term success, and that they're going to invest in a probability, increasing the probability of our success. We're going to increase the probability of their success. And I think as a society, we have to sort of do that too. Do we need every single organization sequencing the genome and having the highest, the fastest technology to do that? We duplicate things more than we can afford anymore. So I do think we need to look at the incentive issues to ensure that when we look at the NIH, that we don't have the NIH provide funding to things that could be done by somebody else through incentives, and say the basic research that great research institutions can provide to really advance knowledge, that's what they have to focus on, and then we have to work on building those collaborations. But I think the consciousness of really having a desire to help the other party and finding parties who share that vision and that passion, that you can make a real difference in it. I do think on the other question of reproducibility of data, it's a tough one. We work in regenerative medicine. We as a company, and maybe something I shouldn't brag about, have invested more money in stem cell research than any other company in the world, and we're now 13, 14 years into it, and we can't tell you that we have the great answer yet as to where we should be. And a lot of that, and that's field, we've seen all the questionable early preclinical data not be reproducible. And so I think, fortunately, a lot of that happens at early stage where the costs of it are not so severe. I think we just have to be very rigorous about the peer review process, and for us to advance our own investments into where the costs become more significant, we have to have that reproducibility, and that's why we believe in building networks with more than just one partner, so that we have the ability to really, if we believe we have something that is going to be transformative, that it's substantiated.
Thanks. I just wanted to make one comment that having spent some of the summer going through the 21st Century Cures Bill with a fine-tooth comb, one thing that's in there that I think few people pay attention to is a demand for the NIH to look through their portfolio and reduce redundancies. So I wanted to follow up on one of your earlier.
Could I follow up on that too? And
Sure.
Rick, this is important. We have redundancies in the Virginia budget too. And you know, I notice as we look at cancer centers and research and things like that, I personally think the way to get success is to have a really big bench, and then when Texas A&M hires your superstar, you got another one to step up. That's where I think we should be in getting this done. But you know, the trick here is that we need to be sure that we're not doubling up our spending where we don't need to as well.
Other questions?
Daniel Czarniawski from the Center for Diabetes Technology. I like the way it started when the word revolution was mentioned, the IT revolution that is coming, and that triggered a question from the Secretary as well, when you say where the money goes. The revolution that the IT can bring is prevention. For example, diabetes was mentioned, and diabetes can be, a lot of complications on diabetes can be prevented with IT, because there is a lot of wireless data that can come, a lot of analytics that can come with that, a lot of big data that can be analyzed and create a physician dashboard that will make more efficient those 5, 7, or 8 minutes that the VA doctor have to give the patient what they need in those moments, with a lot of things in behind. So if we can, at some point, prevent and put more money in prevention, will give you probably, when you ask the question, where do I put the money, where the money goes. So if we prevent and you save in admissions in the hospital, in complications, then you can spend some of the money in affordable house for that person that kept the legs with that person, and in the roads that person can go when still have the 2 legs. So the revolution in IT, it's great, we just need to apply it, and the tools are here. The tools are here from a decade ago. I don't know why we don't apply it. So how much the Commonwealth is willing to invest in prevention? That's my question.
Okay, a couple of things. Yes, there is a lot, and I am not negative on the possibilities, but what I'm reminding everybody is there's a lot of stuff that we already know, like you're talking about, that's there today that we can't even get out to the bedside. And I'm not sure, quite honestly, that it's simply a Commonwealth problem as we look at innovation. I am not one who thinks it's going to be a one-size-fits-all solution for the country. I really don't. What you can do in Wise is very different than what you can do here in Charlottesville, and probably different what can happen in Northern Virginia because of density. Time and distance create huge, huge obstacles. Anyone who thinks one size fits all, you know, has not even been to Minnesota, where you have the Twin Cities and Rochester and everybody else. So, you know, it's different. So that's one thing. The second thing is where we're straddling right now is we are in healthcare restrained by Medicare. When I was on a panel 2 years ago at the Center for Value-Based Insurance Design, and somebody says, what's the biggest obstacle to innovation in healthcare right now? And it's the payment system that is imposed on us centrally from Medicare. That's why the SGR and everything else has to go away, and hopefully we're at this tipping point where it will go very, very quickly. And no one will like it because it will be very unsettled for a while as lots of things pop up. But when the delivery system can't live in 2 camps. We can't live in a value-based system where we get paid to keep people healthy, but keep a hospital open where you get paid for how many days their head's in beds, right? So the issue is going to come as we drive this down to when the systems are going to say, you know, now the incentive favors the prevention, because we aren't able to do that at the state level. I mean, if you think we can do it at the state, we can put incentives in place, and in fact we do through, we buy through our state employee health plan 510,000 lives that we buy, and we try to align that with the Medicaid program, and we've tried to work with the private sector around how we buy, and in fact, you know, it's created some issues with insurance because the big insurer in Virginia is typically paid reduced fee for service for everything. So if you need models, we have to change all of that. But we've got to get Medicare on board.
Could I add something? Yeah. I think one of the things about information technology that I think we have to be a little bit careful on is, and I do share your optimism about how we can impact the cost curve with prevention and information technology be part of it. I think we don't want to hype it too much until we actually can really demonstrate and prove it, because that may retard our ability to really adopt it when we actually have the ability to do it in different ways, whether it's wearables and all the different technologies we have. But the other thing that always comes to my mind when we have these kinds of discussions. I really worry and wonder, are we really serious about dealing with these issues as a society? That's why I think talking about them is so important. And I think about, their estimates to say upwards of $750 billion a year of what we spend in health care is wasted. $100 billion of Medicare and Medicaid fraud. We spend close to $170 billion a year treating smoking-related illnesses. And we're proud of the fact that smoking has gone from 30% to 17 or 18%. Doctors smoke at 2.5%. If we had the whole population smoking at 2.5%, we'd have $100 billion more a year to reduce expenditures or invest it in places that we could either further innovate or further reduce costs on. We have so many things that are wrong with the system, and we don't ever really attack those. We don't have the resolve and the willingness to really make the changes that gives us potential for some of the resources. So prevention is incredibly important. I also think we have to be willingness to attack the issues as a society that says, if you want to live this lifestyle, you have to pay a different. In our company, we're only allowed to differentiate between someone who lives the highest, best healthy life to someone who doesn't by 30%. That's the law. They don't allow us to say, let you pay the full burden. We pay 90% of our employees' health care benefits, and we want to be a great employer in that. And so we have to have all the tools to really change the issues that can affect cost.
If I were going to add on to that, which, well, earlier I mentioned the dichotomy between economic development and jobs in health and healthcare, or in where we spend our resources. We in Virginia live off of tobacco industry in no small part. Our largest industry is agriculture. Without Altria, it's a lot of jobs in Virginia. What do you do in that situation? Do you really attack the industry and get rid of all those jobs? Do you engage in harm reduction, which was the theory, until about 10 years ago? And so we have this balance that you try to weave through carefully, because putting everybody out of work is not going to solve a lot of problems either, but yet we all know that tobacco is probably where it is. And what are the industries we are now supporting here in the Charlottesville area? Alcohol, wine, craft beers are growing. We're spending public money to entice breweries to Virginia. I like it in a way, but is this really where we should be, and as a society? And we are on one hand investing in this because it's jobs and economic development. On the other hand, everybody in this room will say, not so fast. So we need to think about that. Sorry, Joe.
Well, I'm a wine drinker, so go for it. Yeah, there's a difference between commercial policy and health policy. That's clear, right? I mean, there's a difference between business and theory, too. And one of the theories that a lot of business people have, and I'm delighted that they have it, is that they're paying the health benefits of their employees. They are the conduit through which the money flows. There's no question about that. But the employees are earning the benefit. And so it really is of great interest to the employees to have a much more efficient health system and to have smarter health insurance.
Yes, Ed.
Sounds like realizing the promise is going to be a challenge, folks. But Joe, in your opening remarks, you said support for this initiative of medicine is going to be difficult because of the spending rate. As an economist, would you feel differently if the baby boomers redirected their $1.5 trillion of discretionary revenue toward this kind of medicine approach?
Well, I'm not exactly sure how you do that in a market economy. I do know how you do it in a command economy, but in a market economy, the answer is not that people en masse donate their money to something or other. It's that products are available and we buy them. So, in fact, it is up to the health industry to come up with the products we want to buy. It's not up to the consumers to figure out, where to put their research dollars because they don't have a clue. The industry should know, what direction they should be going. I think that is also kind of the message of precision medicine. To me, it's a sign that, and I'm not talking about the drug industry, I'm talking, again, that more general sense. I think it's a sign that everybody in the general health industry recognizes that it hasn't been working for the last, I'd say 50 years so far. Finally, we're getting pretty close to some sort of an economic wall, some kind of a social wall. Certainly one of those walls is us aging baby boomers, because in another 10 years or so, we're really going to be sucking down healthcare in a big way. So for you young people, you only have 10 years to go before I drain you dry.
The interesting thing, I think, when you read about the Steve Jobs stuff, I mean, this is not an Apple, but who knew 15 years ago we needed these? That's what's happened, and now I'm pleased to know that most people haven't been looking at their email while we've been talking, but we all do that. So who knows? And it took an industry to develop this to create the demand for it. So I think that's probably what should happen here. And
I think it will. I think it will.
It's inevitable. And there are, the wall he talks about is real, because as an orthopedic surgeon, I used to think, okay, 18% of GDP, well, that's great. Maybe we should spend 22%. But the challenge is, and this is the call and response part of this, who pays for all of this? We do. Who pays for all of this? We do, right. There's no government out, well, there is a government out there printing money, but by and large, we are on the hook for that. And so whether it's it's government money, who's paying? We are. Say that louder. Y'all don't get this in Charlottesville. Who's paying? And the challenge is, when you run it through the business community, that's wages, which makes them not competitive with the countries that are eating our lunch on jobs. And that's where the economic wall is hit, or ceiling, if you will. It matters.
It's taxes more than wages.
So not seeing any hands, I'm going to actually, oh, I'm sorry, go ahead.
Yeah, I think that microphone wasn't on. I think we can probably repeat it. We can repeat it. We can repeat it.
So I think the question to each of the panelists, and I'll invite you all to add, is around whether there can be a shift to take the incentive away from, I'm sorry, actually, I'm not paraphrasing well. Yeah. So, not shifting it to the government.
But it's really insurers, because it's a shift from private insurance under 65 to Medicare.
Government. Yeah, right. What can be done to address that? And I guess probably from each of your own perspective, if anything.
I'm not sure I understand the question. To make sure I understand the question, Ian, sorry. It's changing risk from whom to whom?
With changing where the costs of a new innovation are being shifted or borne primarily at the end of the day by the government, versus other ways of doing this where that's not the answer for a new innovation.
Would you like me to plunge in and blurt out something?
No, I'll agree with you.
No, you won't.
Okay, but I'll try not to disagree too much.
The root of all evil is government subsidies. Especially if it's government subsidies that are attempted to be administered by the government. Ultimately, that's a problem. So I'm not arguing that we should get rid of Medicare, but I think we should, in essence, privatize Medicare more thoroughly. We have a Medicare Advantage program. It accounts for about 30% of enrollment right now. That's largely, I think, due to the baby boomers who actually, after a year or two in the regular Medicare program, find out that it's really not a very good health benefit. If most Medicare beneficiaries end up in private plans with a clear understanding of what they're entitled to, what their subsidies are, what they're paying for, then you have a much more realistic situation for them and for the insurance companies, because it's the same insurance companies. Medicare is run by private insurance companies, but they're administrators now. They need to be active participants in the Medicare market just as they are in the under 65.
Go ahead.
Just to put it a little bit from the drug perspective, the drug industry is a global industry, and so if we had this discussion today, and the difficulty of describing what precision medicine is, if we could have the same, and I've been on panels and conferences about value, and we say value in the healthcare system, you try and get a definition of value, it's as difficult or more difficult than what is precision medicine and the implications of it. And so, but I think from an industry responsible for developing the innovative products that have a potential for solutions, we live in a value-driven world already, and in a sense that whether you have if you can't be a leader in the pharmaceutical industry if you don't understand and as your core fabric value added is pharmacoeconomics, health technology assessment, that the whole economic proposition that underpins the cost and expense of and the value of your medicines. And that's done all around the world. It's done in the U.S. relatively effectively also here. So there's an incredible alignment about precision medicine and where the industry, our industry is. We see the fact that we live in the world where, despite all the things you hear in the newspapers, which have been in the newspapers for over 100 years about drug prices and this, and we could spend a whole day on that topic, and it would be great to be able to spend that amount of time on it. It is a value-driven system in the end. There are anomalies, and there are plenty of examples of things that don't work in the short run well. But we really believe it's in our interest to find targeted precision medicine. We want to have our medicines only used by people who will benefit from them, because in the end, that's what's sustainable as a business model. Having somebody pay, every single person pay, and only work in 30% of the patients, how do you price that? How do you do that? When in fact, if you can and identify that right patient populations for your therapies, it's a much better business proposition. It's the one that virtually all companies operate under. So we're moving in the right direction, and the technology is allowing us to speed that up. And there's lots of things that need to be done so that we can reduce the cost of development of drugs from all the numbers that Mark talked about. And we've gone way overboard, and some of it has regulatory requirements of clinical trials and other reasons. But we've got to use technology to change that. And lots of promise on that front of speeding up drug discovery, development, and regulatory review and access to patients. But that in the end is not necessarily going to change the economic component, because I'll be very frank with you, if we discover a cure for a certain disease, it's not going to matter to me whether it cost us $400 million or $4 billion. It's the value of that medicine that will determine what I will be able to get paid for it, not what I spent to do it. And so that talk to me is a little bit the industry ourselves, and I'm the chairman of the Pharmaceutical Industry Communications and Alliance Committee, so responsible for at least our Washington, D.C. focused communication strategy. It's value. What is a fair return on the discovery and the benefit that we provide? And so, but a lot of positive things going on, and there's not a lot of lack of alignment about really how we're doing it and what's happening. We've got to get better at it. We've got to find the better solutions, but I think we're really moving in the right direction.
Yeah, I'm going to try to respond to him and then try to answer your question, because I don't think they're the same. But you know, the issue of value is really important, but value to whom? And being in the land of Mr. Jefferson here, what happens when and this will build a little bit on, but a more nuanced view of what Joe has said, what happens when we supply or subsidize both the demand and the supply? And that's what we're doing, I think, when you get to over 65. We help generate the research, because that's an economic development tool, and we get into that business, and then we subsidize the demand. And that means that there has to be some substituted judgment on value. And that's, I think, really where the challenge is here. Frankly, what I say in land of Mr. Jefferson is, look what's happened with education costs. When you subsidize schools and then you give students loans that they don't really expect to ever have to pay back or they don't understand, the value gets skewed. And so, it makes it hard for the individual to determine. So, that's an issue. So, in terms of the problem I see with healthcare, the private system theoretically works up to 65, and even in Virginia, all of our basic health care is done through Medicare or through private MCOs. The challenge is when you get to 65, for the most part, you're into a fee-for-service Medicare program. Suppose it was possible that what those plans wanted you when you were over 65. I mean, I think that's what we have to rethink is if you want that plan to have you over 65, how do I keep you in a lifelong relationship with that insurer? And then you begin to have this aligned. And I don't think we were having that discussion yet, but I think that's important.
I'd like to actually follow up a little bit, and this is a question to you, Bob. In realizing that Celegene's business model is not necessarily in the chronic disease space, but part of what we've been talking about as a panel has been around issues of prevention being probably a primary need. Given, I don't know what your vision statement is for your company, but I'm sure it gets to health of individuals. Is there a role in pharma, and again, I'll ask you just in a broad sense, to not only produce these medicines, but to help incent the systems that look at things like how patients take their own health into account and use the medicines properly? I mean, is this more than just giving pharmaceutical precision medicine, or precision medicine-based pharmaceuticals to the public? Is there a role for the companies to look at it and say, I'm going to actually help the system use this responsibly, and by the way, also get patients to do the right thing, or look at how they do the right thing?
No, I appreciate the question, and it's a difficult one in the sense that in some ways you have responsibilities and stakeholders that would say this is how you should do things. Certainly our view at Celegene is a more holistic view of the impact that we can and should have, and the capabilities therefore are designed for long-term impact. And if we don't impact the system in the most effective, holistic way possible, how do we really believe our future will be as bright as it can be? How will we believe we'll attract the very best people to do our research, to do all the things that we want to do as a company? And I do think generally, having been a real outsider from a startup, little small company, when I joined Celegene, we had 6 weeks of cash left, and today we've been relatively successful over the last 16 years to have much more of an impact in the industry. But we still view ourselves a little bit of an outsider, and I joined the board of pharma 8 years ago or so, and I had a very certain view of big pharmaceutical companies, and now I'm friends with Ian Reed and Ken Fraser and John Leckletter, all the guys that run these big company, Alex Gorski and stuff. And I really do believe they have a vision that their impact needs to be beyond the shareholder. The shareholder's got to be critical to determine your value. If you don't have the ability to have the financial flexibility to continue your business, you can't have long-term impact on patients. But on the other hand, I think we all recognize, and that's why I certainly like to come to events like this, is that if we don't find integrated, collaborative solutions for these issues, if we don't discuss them in a way with the right people at the table who can have very different views, we're never going to get to, because if we all just sit in the echo chamber and we're all of one viewpoint, that solution is unlikely to be the best solution. So I think even on the social issues that we find in Washington, where we're very engaged, and a few of us were at the White House a couple weeks ago to talk about how do we advance some of these issues in a way that gets more collaborative, more bipartisan. This one happened to be on the Trans-Pacific Partnership issues. But so I think the people in our industry do believe that business model means if you don't impact on patients in a positive way, you don't have a sustainable business model. And I think that if you don't impact the system, that allows the system to have the ability to value your innovation what good is it? And you're not going to have the ability to have the ecosystem. And we also really strongly believe is that when you think about the ecosystem of biomedical innovation, what Rick was talking earlier about, whether it's academic medicine or research universities, small companies, large companies, insurance companies, state health secretaries, think tanks, et cetera, the whole ecosystem needs to be healthy if we're going to, one, deal with the challenges we have, but ultimately find the solutions that we need to if we're going to take advantage of all these investments that we've made and really have the longer and higher quality of life.
Bob, what I fear, I hear what you're saying, but yet I go home and I watch the advertisement for the most expensive, latest brand name medicine, which none of my patients ever needed, or maybe a few did, but they don't know that when they see the marketing. And I mean, yes, it's good that they now know about things and they come in. On the other hand, that's time that I have to take. I could spend a whole visit explaining why this less expensive medicine is probably just as good and maybe safer than the one that hadn't been in existence long enough, which just wasted a whole patient visit from my standpoint. Probably didn't help the patient very much either, or sell them the more expensive medication and bill somebody else for it. The culture that because I have the insurance benefit, I want everything my benefit entitles me to, it's a very American sort of solution. And why I think we've run into problems on the Republican side of things is we tend to think of markets, but insurance is inherently socialistic. Everybody puts in something with the idea that you get it when you need it, but we want everything up front, first dollar, and we want every bit of it that we're entitled to. And I have a trouble balancing that. So I just, in the interest of the robust discussion you just called for, I have to point out that the marketing is really important.
You know, I'm going to real quickly rebut that somewhat. Listen, I have 3 kids, right? And I didn't like the fact that when my daughter was 8 years old, she'd ask, "What is erectile dysfunction?" And I think it was one of the great things that damages the reputation of the industry is that you have direct-to-consumer advertising of products that not necessarily are the pleasant things to talk to people about. I happen to be a great believer in the free market system, and I just refuse to believe that a doctor shouldn't be given a pen or a pad as a tchotchke, which I don't think is any great value, because they're going to give my grandmother the wrong medicine because they're told to do something by a television ad or a patient that comes in and says, "Listen, I think I might have psoriasis. Let me give you this drug." And I'm thinking to myself, no, I have faith in doctors. I want to keep the doctor and the patient ability to really decide how medicine is practiced, and I think we should hold doctors to a high standard to ensure that they do what's best for the patient. But I don't disagree that there are, but I'll also give you, in the Affordable Care Act, we offered as an industry to give up the tax deductibility of direct-to-consumer advertising as a trade-off about other things. So I think when we think about the cost, we can't be, none of us can put our head in the sand and say, if we're going to solve these issues, and
I agree. We write the prescriptions,
we have to all be into the solution.
I agree, and I tell doctors, I'm an equal opportunity, disconfirmer, if you will, because I'll tell doctors all the time that ultimately we're in this game because we write those damn prescriptions. Nobody gets anything without the prescription, but yet there are ways to help us, and there are ways that work against us. And part of the issue that I see with some of these new things coming out, that there will be the next marketing blitz, and then they'll be coming in looking for stuff that's not ready to be in the delivery system yet, and that the doctors don't know a thing about, and we can't mandate CME. So who actually is going to be entitled? It's like some medications now are limited to certain specialists, and from the public, how are we going to address that delivery system? And I think we need to be. There's a lot of thinking that needs to be done in a timely fashion if this is actually going to work when it rolls out to meet your needs too.
Yeah, I think we have to figure it out.
So we've got 4 minutes left, and I'd like to go back to the question I posed earlier, which is I'd like to hear from each of you if you could direct a center of health policy or a consortium of centers of health policy to undertake some issue of area of research, what would that be, if you can identify such? Go ahead, John.
Yeah, well, actually, this is an emergency, and because you mentioned Mark, of course, it's an easier one to point at him because he ran the Medicare program. As he mentioned last night, the physician payment fix didn't actually fix anything. It mostly left a bunch of words that sounded good and no substance whatsoever. And so I would like his center and anybody he's associated with to partner with the private sector to develop useful and real alternative payment mechanisms, and not things we call alternative payment mechanisms. And more importantly, not just come up with a formula, but actually learn how they work. It's an odd concept in government. And
Be nice. I mean, we do try sometimes.
Medicaid does more than Medicare. A development improvement process. This is not something that is easy to swallow in government. And the worst part, we talk about transitions, but we need a transition. We cannot get from here to there, whatever there is. So I think that's a pretty big challenge. But he has to do it in the next 3 years.
I would offer a couple of things. First of all, we do have to align incentives in the system better between government and the private sector and the patients, the consumer engagement. That we've got to figure out ways to do that. So I would ask for kind of honest, sort of non-judgmental studies of different models that actually work in different situations. That would be one. And number two, the tendency at the General Assembly is going to be to look at the last hacker event and say we got to close down all sharing of information. And we can't let that happen. We need to be out there saying we need this for appropriate use with appropriate security, and we got to make these systems work. Because I think the biggest threat to all this is getting shut down on the data sharing arrangements.
I don't want to be too presumptuous, because I think you all probably know best as to where your expertise is and where to focus. I do hope that you do focus on information technology, because it is something I think that resonates with young people, middle-aged people, and hopefully older people understand the importance of it in their lives, impact. So I think where you can weave that in is very important. I do think, and one of the things I've spoken to others here about, is I do think the university has a very unique position to be a convener on these topics, whichever ones you choose to really have an impact in the society with, because of the law school, the medical school, the business school, the policy schools, and bringing that together. And I do think that really fostering an environment where you bring people of very different perspectives together who have one thing in common, that they are looking for constructive solutions, as opposed to there are people out there that have a vision that this is the only way it can be, and I'm not so sure that's, but I think having collaborative, constructive engagement with all the different sectors that in the healthcare system is very important. And then I think, to a little bit what Bill and Joe said, I think demonstratable, achievable type of outcomes, because we do need to demonstrate that we can produce measurable evidence of change and outcomes, and therefore have a real impact, not just from a philosophical point of view, but actually changing the way we deliver healthcare.
All right, thank you. I'd like to ask for a round of applause for the panel.
Nobody wants to.
We may want to throw things.
Outcomes that matter to people.
For the